Hello, my name is Jacqueline Garcia, and I'm an adult leukemia investigator and clinician at the Dana-Farber Cancer Institute in Boston, Massachusetts. And I'm happy to answer this question. Um, High-dose chemotherapy or intensive chemotherapy is one of the approved and available regimens for our patients with a diagnosis of acute myeloid leukemia. And there is still very much a role for high-dose chemotherapy. We also call it intensive chemotherapy, but it might not be the best therapy for all patients. We are still struggling to understand who are the patients that should get it and who should not be, and we have a lot more work to do. But I think some of the encouraging data that we've learned over the last couple of years based on clinical trials, recent approvals, and outpatient experience is that we have more to offer our patients today than we ever have. And based on characteristics of patients, including disease genetics, functional status, performance, whether or not patients are interested and willing to undergo a transplantation, do they have donors, we now have to think about all these different complex algorithms in order to understand what a patient's best frontline therapy is. And so high-dose chemotherapy is a treatment that we've used historically to treat acute myeloid leukemia with the goal of getting a patient into a remission. And remissions mean that we hope that the bone marrow can be cleared of the leukemia blasts or the leukemia disease burden, and that there could be count recovery. But one of the things we know is that for most patients that are diagnosed with acute myeloid leukemia, high-dose chemotherapy represents the very first step of treatment, and more therapy is still necessary to keep people in remission or to keep them and keep the disease away long-term. And unfortunately, it took us many years, in fact, decades, for us to improve upon this therapy. And high-dose chemotherapy does come with risk. Not everyone is recommended for it. It does come with a long inpatient hospitalization, which could be very difficult for patients, understandably so, and their families. And in particular, during a difficult time like this, during the pandemic, long-term hospitalization, being away from the family is really hard. But high-dose chemotherapy can benefit some. So when it's recommended, it leads to long-term hospitalization, but there's risk of treatment-related toxicity, including serious infections and potential for organ damage. But generally, when possible, clinicians make a decision of, can this patient undergo a high-dose therapy or not? And if they are not recommended for high-dose therapy, is there a suitable alternative, or are there disease features like mutations that make me feel that maybe high-dose chemotherapy is not their best option? So very fortunately, in the last couple of years, we've had approval of drug combinations that are not high-dose chemotherapy. They're less intensive strategies. Some examples include venetoclax plus hypomethylating agent, venetoclax plus cytarabine, glazigib plus lodocytarabine, even IDH1 inhibitor therapy alone. And these are all therapies that have been approved for frontline treatment of acute myeloid leukemia for select patients. These are patients who are, quote, not able to undergo intensive chemotherapy. And that could be either because patients are 75 years and older, or maybe they're younger than 75 and they happen to have terrible comorbidities. And comorbidities mean other diagnoses and ailments that could be making them sick at baseline to start, like maybe a patient has heart failure or cirrhosis or another serious cancer. And so maybe giving them the most intensive treatment is not the safest thing to do. And so the clinical trials of the last couple of years have been aimed at an older population because that represents the bulk of our patients. And with these recent clinical trials, it's led to approval given the demonstration of improvement of these novel therapies compared to the standard therapies that otherwise would have been available for these older patients. We are waiting for, and these processes are underway, data to confirm which is better, intensive versus non-intensive. We don't yet have a data readout for, as an example, 7+3 intensive chemotherapy versus the now popular venetoclax plus azacitidine. That's the type of the data that we need, so we can say that patients who are fit, who are able to get any type of treatment, which one would be better? Do we really need to hospitalize patients and increase risk of toxicity with high-dose chemotherapy? Can we instead give them less intensive strategies. The last thing we want is to compromise efficacy or chance of durable remission or bringing patients successfully to transplantation. So that data still needs to happen. Those trials still need to occur so we could give patients more answers. But the horizon is looking good. We're finally getting treatment options that are not high dose chemotherapy. So now we have a little bit more flexibility and can really tailor our recommendations to patients. In particular, if you have baseline medical issues or you're older and frail, we now have options that were not present before. And so you don't have to get high dose chemotherapy anymore. And I think that is the most encouraging thing the last couple of years. I'm really excited to see what happens in a couple of years when we get the readout, hopefully, and more data on intensive versus less intensive. I don't think that the new therapies will completely replace high dose chemotherapy because high dose chemo is still very effective for a good number of patients. And a lot of our younger fit patients really can do well with these treatments and get into deep responses. We still need that data to see which is better, but I'm hopeful with our more mature techniques and lab strategies, we can understand which patients should get what therapy. But the treatment arsenal is really improving and expanding.